Hi, I'm Nathan Fountain, Professor of Neurology and Director of the Epilepsy Program at the University of Virginia. Welcome to the Epilepsy section of the meeting. In this section, we're going to discuss the presentations I hope you've previously viewed about the epilepsy abstracts from Dr. Sijia Guo, from Dr. Vibhor Krishna, and Dr. Xiangyu Yu. Please submit your questions and we'll try to get to as many as we can. And maybe I'll start with Dr. Guo. And you compared 670 kilohertz, the standard kind of high frequency system, to the 220 kilohertz or a low frequency system for ablating a model, I'll say, of MTLE through simulations.
Yes.
And it looks like in the low frequency system, you found more scatter and sort of less well-defined focus, I might say.
Yeah, that's
cause cavitation. And so my question is, first, is there something about this particular use of the low frequency system that makes it more concerning for causing cavitation, or is it just a general concern with the low frequency system?
Yeah, of course, cavitation will be a concern, but I was only looking at the power transmission, like the heat absorption efficiency and how the focus bulb looked like as the first step. So of course, cavitation will be a huge concern. So that's why we thought like the 220 kilohertz system is not good for the thermal ablation in this case.
But do you think that's particular to this site or method of stimulation, or do you think that's just a general concern with the low frequency stimulation?
Yeah, it's a general concern, yeah.
Okay. The second question's kind of asking you to extrapolate a little bit and ask your idea about what you think might be the generalizability from the model you're using now with the phantom inside a skull to actually human patients. Do you have an idea about how that's likely to translate? Does it typically translate well, or is it likely to have some unexpected findings?
Yeah, there are obvious something different from like a real patient. First, like there's no perfusion in a phantom. And the second, the skull is different. It's a cadaver skull is different from a live human skull. So actually the perfusion decrease the power, they decrease temperature in the treatment. But what we found on a cadaver skull is that it's lack of the trabecular bone. Some of the trabecular bone disappears after the procedure. So that actually decrease the power transmission. So if we consider those 2 points of view, it's maybe close to a human skull because of less of perfusion, but more attenuation in the skull. So that's the 2 parts I considered.
That makes sense. We have a question from the audience. How many thermocouples and where were they placed on the skull surface, and were there anything inside the skull? Was it similar to the standard clinical system we use or something different?
Yeah, it's the clinical system. So I'm using the clinical system and place the 4 thermocouple in this study. All are close to the predicted skull heating from the model.
You were able to reduce the skull heating by about 3 degrees through your manipulations, but I guess that still means it was 7 degrees above normal. Do you think that's likely to cause a problem, or do you think that'll not be high enough temperature difference to be an issue?
That's a good question. So we actually discussed this with our neurosurgeon, like Dr. Fishman, about the temperature. And we have a general idea that maybe like the temperature rise on skull below 10 degrees, maybe something we can deal with. So that's what I am trying to like set up, what I'm trying to, what I'm aiming for in this project.
That makes sense and seems reasonable. The last one's a rather practical question. I think clinically we wrestle with all the time. And if this is consistent ultimately in the clinical application, then how many sonications or for how long do you think will be required to do something like ablate the hippocampus? So just kind of roughly, if we figure there were, I guess, 3 sonications per site, if you said maybe there were 6 sites, then maybe that's 18 sonications. I'm just making this up. But if you wait 2 minutes between sonications, that's sort of a total time of sort of 45 minutes. Can you make an assessment like that? You think that's a legitimate assessment, or do you think it might be longer or shorter than that?
Yeah, I think it will be longer. So after we discuss about the cooling time, we're probably gonna need more cooling between each sonications, because what the data I don't have is like how long does it take the skull to be like to the temperature to go down in the skull. So we actually expected a longer cooling time between two sonic, but I didn't quite understand why there are like 6 sites need to be treated. So
I'm just guessing if have you done a calculation about how many sites you'd need to treat to ablate the whole hippocampus, if that was your goal?
Yeah. But in the simulation, I was looking at 5 spots.
5?
And, but there's only one sonication on each spot. So there's not 3 sonication on each spot.
Oh,
so
right.
Total is probably like 5 sonication if we are sonicating at the maximum power proposed.
Okay, that makes sense. And another question from the audience: what were the SDRs of the skulls you used in your tests? Were they consistent or a diversity?
There are diversity. So they goes from 0.3 something to 0.5 something. So, but there is no problem to creating temperature that is higher than 50 degrees at like the mesotemporal lobe. But we need more time to acquire more skull heating data. So the target heating is not a problem in the 3 and 4 skull that we are acquired.
Okay, I guess that makes sense. Yeah, thank you. Maybe we could move to questions for Dr. Krishna. Please enter those also in the chat, as well as for Dr. Yu if you are watching and accumulating questions. So, Dr. Krishna, you did unilateral anterior nucleus ablations for patients with intractable epilepsy that had secondary generalized seizures as a safety study, and you've treated 2 patients so far who both seem to have substantial reduction in their seizure frequency. And 1 patient had a decline in verbal learning. So I guess my question is, what's the longest duration you've been able to follow up on the patients to see how durable the effect is?
I think he's muted.
I think you're muted, Dr. Krishna.
Sorry about the muting. Longest follow-up we have, Dr. Fountain, is 18 months. And the last patient was followed for 3 months. So he's continuing to follow up.
So that's a pretty good follow-up time. A second methodological question is, I don't think about the anterior nucleus much except outside of DBS, where the actual boundaries of it I don't really have to think about. But based on your presentation, it seems like kind of a large area, which maybe that's just edema, or maybe that's the size of the anterior nucleus. I never quite thought about in that view. Is the lesion, does it constrict over time to become smaller, or is what we see actually the size of the anterior nucleus?
So 24 hours afterwards, you're right, Dr. Fountain, that the size of the lesion is significant enough that it involves the entire anterior nucleus, which is a sizable nucleus. We're used to thinking in terms of VIM. Anterior nucleus is roughly twice the size of VIM. So it's a big lesion, 24 hours. But when we see at 3 months on T2, we couldn't see the lesion. It was indistinguishable. And so on diffusion MRI, though, we could see that there were microstructural changes that were there in the entire anterior nucleus.
Okay. So you couldn't find any evidence after
No.
6 months? Yeah.
That's why I put the sagittal scan. So it's very interesting that you see a big lesion right afterwards and then it disappears at 3 months. And the interesting aspect about anterior nucleus is it's very easy to heat. It's in the center of the brain. And so sometimes temperatures can be very high. And so I imagine that high temperature is associated with a lot of edema afterwards as well. So that's what we see 24-hour post.
Well, that's a nice segue to my next question, is because the patient had a decline in verbal learning, which is, I guess, you might expect in some ways, although it's unilateral. So was that something the patient detected or something you found incidentally on testing?
Something that the patient detected. And so they are very high functioning person. and they are actively working as well. And so in the follow-up, during the follow-up, they brought it that they noticed that there is some changes in their memory, and we have a very extensive battery of neuropsychological testing, and we found during those testing that in fact they had a decline in verbal memory.
How do you think that unilateral ablation may prevent seizures that secondarily generalize? You might think to go bilateral either through the bilateral anterior nucleus or through other pathways.
That's a very interesting question, and I honestly I should say I don't know the answer to this question right now. We were lucky that both of these patients had predominantly one hemisphere that was involved in the seizures, and so both were left hemispheric. But still, at the level of anterior nucleus, there is decussation of the fornix, and so information should go on the other side already. So this is actually beyond the decussation, distal to the decussation of the fornix. And so from an anatomy standpoint, I don't know why these patients would have a profound reduction in their seizures just by unilateral antenucleus ablation.
Well, I guess I might ask if you thought about bilateral ablation, but if unilateral ablation has been sufficient, you wouldn't need to do bilateral IVL.
Yeah. So I had that in the back of my mind that at some point we might have to think about bilateral. And the experience is not enough to change that opinion just yet. But right now we are continuing to persist with unilateral and see how these patients do. And we are hoping to enroll more patients and understand what are the limits and how patients do with unilateral antenucleus ablation first.
Maybe you could take just a minute to comment on the criteria for your study at Ohio State. What are the sort of general inclusion or exclusion criteria?
So the main inclusion criteria is that these patients have partial onset of seizures with secondary generalizations, who have failed medications, and their seizure frequency has to be high. 3 to 4 seizures a month or more is what we are looking for. And patients had to have a previous workup, including, either, video EEG or intracranial monitoring. And the main exclusion criteria from an epilepsy standpoint is if the patient has indwelling vagal nerve stimulator or any kind of hardware, we cannot enroll in that study till the patient has removal of that hardware.
Does that mean, do you do that? I guess just need that just to be in the MRI, you mean, and to get the whole procedure?
Yes, sir.
Okay. All right, maybe, let's see. If we move on to Dr. Yu. So Dr. Yu, you did low intensity focused ultrasound and looked at the effect from intracranial monitoring from a handheld device that targeted the pathways based on its projection on what I presume is a pretreatment MRI. I gather it's not actually done in the MRI magnet, and gave 10-minute treatments, and 6 patients completed the study, and all of whom had seizure recurrence in hours to months. But it was previously, I guess, a feasibility, a proof of principle trial, you might call it. If I might ask you first, just a methodological question. Did all of the patients have intracranial electrodes?
Yes, they were all under the condition when we finished our SEEG studies. Before we removed, then we enrolled these patients to this study. So when we were doing the sonication, the electrode was inside the brain simultaneously.
Okay. Mm-hmm. And does that present any problem for the stimulation because the electrodes deflect the waves or change the energy or anything like that?
I cannot answer that, but we have discussed on these issues. There might be some reflection because the artifact when we were recording during sonication, the artifact produced by the sonication intracranially varied among patients. Some are very clean. You cannot see any sonication artifact. But for 2 or 3, we can see some 100 hertz pulse rate artifact produced at a similar rates as the sonication. Yeah.
That makes sense. How large was the target? Did you treat a large region, or did you try to, I guess it's not as small a target as with high intensity traditional focused ultrasound. So with low energy or low frequency, how big was the target in general?
Usually the trajectory, we focus on one pair of the neighboring electrode, and the sonication shape will like a cylinder size 2 by 2 by 10 millimeter, that size, yeah. This, the technique told me that when they simulate the sonication, they will produce a size like that.
So kind of a narrow tube, like you said. Okay. And how often do you anticipate you'd need to do that? Do you have any idea about that? I guess you had one patient was having 50 seizures per day, and they went down to essentially having no seizures. And you contemplated maybe that caused some of their problems. But if you kind of project forward, do you have any idea about how often you'd have to do this in order to help suppress seizures?
Actually, I don't have much real idea on that. We were still working on some preclinical study now. We use separate sonication divided by hours or days, but the result haven't come up yet. But for our experience in this phase 1 trial, we did have a patient, he underwent 2 sets of the sonications separated by 1 hour rest. It's also quite safe. So I don't know what we are going to do, but in our next step, we are going to do the same day, separated by 2 hours, 2 sonication, and reduce the time, because 600 seconds, 10 minutes by this handheld transducer is a little bit tough for our physician and the neurosurgeon. Yeah.
Okay, we just have another minute or two, but just to comment on, so there was a feasibility study that one of the patients had dysphagia that took about 10 days to resolve, and you contemplated maybe that was a kind of forced normalization. Did I interpret that right, that you thought that the physiologic effects on the brain that suppress the seizures also cause the dysphagia, rather than meaning it's a functional problem, a psychiatric problem or something like that?
Yeah. When I saw her dysphagia, I was a little bit shocked. But when I did the neurological examination and I continue to video tap her, see her activities, I found that those impairment was conditional, and she is right-handed, and what I treat is on the right side, and all the manifestation cannot be well explained by the normal neurological system. So I think that was a functional, not really anatomical destruction on her brain. And also I record 2 days of video EEG after she had symptoms, and there is no focal slowing. And
okay, that makes sense that it's functional. Yeah. Well, I want to thank all of you for your very interesting presentations and the questions, and thank you, the audience, for submitting them. Thanks.
Thank you, Dr. Fonte.
Thank you.